fifth or sixth session of Burning Migraine Questions, our Facebook Live. Lots of really great questions that are left over from last time that I hope we'll get a chance to get to, and several other very interesting questions that have come up since that last event, and hopefully some more of you will join us as time goes on, and we'll have even more questions come through as we go through this process. So for the next 20 to 30 minutes, let's begin. One of the real interesting questions is occipital neuralgia considered a headache? Is it considered a migraine? Is it considered something else? I think that's a really interesting question. And I think the corollary to that question is actually, what is a migraine? So let's try and define that. A lot of people will say a migraine is just a really bad headache, but in truth, it is actually a really severe neurologic condition. The problem, from my standpoint, when you're actually speaking to other physicians with regard to a migraine, is that, in my opinion, in many cases, it is a name that we've basically given to a constellation of symptoms. In other words, if you look it up and go to WebMD or MayoClinic.com or anything else, you just Google migraines, what you'll find is that migraines are obviously very severe headaches, and there'll be all sorts of descriptive characteristics. It occurs in this age population most often. For example, women age 25 to 55 is peak incidence. It has X, Y, and Z features. It lasts anywhere from 4 to 72 hours. It can be caused by loud noises. It can be caused by alcohol or something else. People who have it have these auras, so typically there are 4 phases of a typical migraine. So a prodrome, so where you start to feel a little bit off before you actually get your head pain. Then a lot of people, not all people, will experience an aura, okay? And many people know what that is, sorts of flashing lights, etc. Then they will actually experience their headache with the head pain, although there are acephalalgic migraines where people experience the nausea, dizziness, etc. without the head pain, so that even that is not a consistent symptom. And then you have a postdrome, which is almost like a post-seizure kind of period of time where the actual head pain has either abated to some degree or gone away, but you still have confusion, irritability, etc. So you have all these wonderful descriptive characteristics, but at the end of the day, the question is what causes it? And in most cases, the answer is we don't really know. And the perfect example, and again, you don't have to take my word for it, but if you really think about it, the perfect example for the fact that we don't actually know exactly what causes a migraine, certainly not in every particular case, is just the sheer number of medications that are used to treat migraines. And not only that, but the sheer number of classes of medications. So if you look at the classes of medications that are used to treat migraines, you have anti-seizure medications, you have pain medications, you have muscle relaxants, you have neuroleptics, you have serotonin modulating drugs like all the triptans, you have all the new CGRP receptor antagonists, you have antidepressants, etc. And generally speaking, in life as well as everything else, when there are 25 different ways of treating problem X, you can be pretty rest assured that no one of those methods is supremely effective. Otherwise, that's what everybody would be doing. Now, this is not to poo-poo any of the people who make the diagnosis of migraines, but the real two questions in my mind for any diagnosis, but certainly for something like this, is number one, can you actually figure out what's causing the problem? And two, can you do anything about it if you can figure out what the cause is? And I think that's one of the differences between how we as peripheral nerve surgeons begin to address headaches differently than the traditional ways that people are thought to think about these problems. And specifically, if you are looking at occipital neuralgia, occipital just means in the back of the head or scalp. Neuralgia just means nerve pain. The question is, can you figure out which nerve is causing the algia, the pain? And that's really the crux of the diagnostic workup when you come to see me or any of the other colleagues of mine who do these with some frequency. And so to answer this person's question, is occipital neuralgia considered a headache? Well, yes and no. Occipital neuralgia can give you symptoms of a headache because it can cause head pain, and any head pain is a headache by definition. Can occipital neuralgia be associated with and or fall under the classification of migraines? Of course, because if you look at, let's say, chronic migraines, which are have X number of symptoms like the ones we just described and occur more than 15 days per month, you can have occipital neuralgia that often causes pain 24/7 and will therefore meet the criteria for migraines. And so therefore, so many of the patients that come in to see me have been diagnosed with migraines, which is not necessarily inaccurate. It's just not very specific. And so that as a diagnosis doesn't help you very much. And if you ask most of the people who've been diagnosed with migraines and been treated for many, many years, some of those or many of those will actually have been treated successfully, but there are also many millions who haven't. And the reason is because the diagnosis of migraine doesn't tell you what's causing it and how to fix it. So those people end up being treated what's called empirically. In other words, it's kind of like throwing darts at a dartboard. Here, try this drug. Didn't work. Here, try the other drug. Oh, shucks, that didn't work. Try these two together. Darn. And back and forth, because what you're really doing is trying to figure out one thing after another, which problem, for example, CGRP, serotonin, both of them, is it a muscle that's tight that's causing it? And you're just eliminating factors one by one. All right, and somebody asked as a corollary to this, what is a neuroleptic? A neuroleptic is a class of drugs such as Neurontin or gabapentin, Lyrica, Cymbalta, etc. So those are the neuroleptic medications. Hopefully that helps. Someone was asking, how about if several years after my surgery, I still have a hypersensitive or numb area after decompression? What does that mean? Well, let's take the hypersensitivity question first. There are a couple of questions I would have for that person. Was the hypersensitivity present before the operation? If it was, it may mean that the nerve that was decompressed was actually too injured and decompressing it wasn't enough. Because of course, as I tell my patients, if you decompress and leave a permanently injured nerve, that would be sort of like doing CPR on somebody that died a month ago. You can press on their chest all you want and do all the chest compressions in the world that you want, but that person is dead and they're not coming back to life. Similarly, if you decompress and leave a permanently injured nerve, you will still have symptoms. So if the hypersensitivity was present prior to the operation and remains present, perhaps the decompression surgery was not successful because the nerve was permanently injured. And that's not to say that the surgeon did anything wrong. As a matter of fact, one of the hardest things to do as a surgeon is to make that clinical decision in the operating room. So it's sort of a game time decision, and this is what I tell my patients personally. When I see X, Y, and Z factors within the nerve, I make a decision as to whether or not that nerve needs to be transected and implanted in the muscle, or whether that nerve can be left alone, decompressed, and will survive. And you don't always make the right decision. I think there's an old adage in surgery, and that is good judgment comes from experience and experience comes from bad judgment. And it's being a little flippant, but the fact of the matter is the reason to go to someone with a fair bit of experience is the chances that they will make the wrong judgment call at the time of the operation obviously depends on their experience. So the more of those operations they've done and the more closely they followed those patients over many, many years, the more they will have a chances to correctly predict in the OR at the time of surgery whether the nerve that they're looking at, having been decompressed, can be left or needs to be taken. Okay? With respect to the numbness, okay, there's again a couple of issues there. Number one, is the nerve that was operated on permanently injured as a result of the operation? That's certainly possible. If that nerve is injured or has been cut, then you will have numbness in that nerve distribution. There's also a possibility that with respect to both the numbness and the hypersensitivity, that another nerve has been inadvertently damaged or cut as a result of that first operation. And the perfect example of that, which I've seen a number of times from other headache surgeons who I don't know if they're experienced or not, but when they address only the greater occipital nerve, a lot of those patients will come back and see me and they say, I still have this kind of pain and hypersensitivity that I may not have had before surgery, and there's a certain amount of numbness there. And the reason for that is that the third occipital nerve is almost always in the line of fire of the surgical field when you operate on the greater occipital nerve. Now, that doesn't mean you have to operate on the third occipital nerve if you're operating on the greater occipital nerve. However, you must be cognizant that that third occipital nerve is right in that area. And if you don't look for it and move it to the side gently, on your way to the greater occipital nerve, you could very easily injure that third occipital nerve, cut it, burn it, and that can lead to numbness and or hypersensitivity. And it's unfortunately something I've seen a number of times in my practice, but also something that is fortunately relatively easily managed with another operation to take that third occipital neuroma, which is likely formed, cut it a little further back and bury it in the muscle. There's a patient that wrote a really, really, really interesting question that I think is actually extremely important. They said Botox didn't work for my headaches. It actually made my headaches and neuralgia 10 times worse. What gives and how come, okay? And why does it work for most people and it didn't work for me? So first of all, let's talk about how Botox is supposed to work. If you have a muscle, okay, and you have a nerve around the muscle, okay, and that muscle is flexing or squeezing itself, you can actually squeeze or compress that nerve, okay? The idea behind Botox as we use it is to try and relax those muscle fibers around the nerve so that the rest of the muscle can fire, but these muscle fibers around the nerve are no longer squeezing that nerve. And if you get a good result with Botox, it might mean that your nerves are being compressed by overly tight muscles, and that creating a little bit of space by removing just a little bit of muscle, leaving most of it there, will allow the whole muscle eventually to work, but that nerve is no longer squeezed, okay? Botox used according to the initial studies with Botox and, quote, migraines is a different type of approach altogether. It involves, in the traditional preempt 1 and 2 studies, 31 injections all over the head and neck, using smaller amounts of Botox in each location. The problem with that approach is that if you inject enough Botox, of course you'll relax something. But let's say you've had a home run result. So, and I think we've covered this in previous Facebook Burning Migraine Question, Facebook Live Burning Migraine Question sessions, but it bears repeating. Let's say you have Botox and it works gangbusters. You have no headaches for 3 months. That's terrific. Which of the 31 injections that you got was responsible for that result? Do you need 31 injections? Or maybe you only need 21 injections? Or maybe you only need 1 injection? You have no idea because they were all done simultaneously, and Botox takes several days to become effective. And so the problem with that approach is it doesn't really tell you much from a diagnostic standpoint. You know that there's this treatment that may be effective, but it doesn't tell you what the problem was, because presumably if you have headaches in the back of the head and you're injecting Botox here and the back of the head and it worked, the question becomes, were these Botox injections required to make these Botox injections effective or not? You don't know. In addition, the numbers with regard to those studies were really not that impressive. And so I would dispute the fact that Botox works in a huge number of patients. It can be helpful, and I've certainly seen patients who do extremely well with Botox. So is it reasonable to try once or twice? And if you get great results, to continue on? Of course. But most of the people that I see, and granted my experience is somewhat skewed because I see the people for whom Botox fails, it certainly does not work for everyone. Now, getting back to the original question, when I got my Botox, it made my headaches worse. Why is that, and what could that mean? Well, it could mean any number of things. Number one, when the clinician injected the Botox, they may have inadvertently injected too close to or within the nerve. That's pretty unlikely, but it can irritate the nerve, as any injection can, okay? So that's number one. Number two, if you inject too much Botox around a muscle and you weaken that muscle, the remainder of that muscle will try to work even harder in order to maintain the function of that muscle. So think of it as someone who has to give up a kidney to a loved one, okay? You have 2 kidneys, you're gonna give one up. Most physicians will tell you that that remaining kidney will be able to more than adequately take over the function of the kidney that you're donating, okay? But that second or remaining kidney has to now work overtime. Similarly, if you have these muscle fibers and you have this nerve and you're trying to Botox these areas, but inadvertently you Botox these areas, these become weaker. And so therefore, these muscle fibers are going to try to squeeze even harder to compensate for the fact that these don't work. And if these muscle fibers, the ones around the nerve, are working overtime and working harder, they are actually going to squeeze those occipital nerves in this case even more forcefully than they were pre-Botox, and your occipital neuralgia, if it's caused by muscle contraction, can actually be significantly worse. So that is something that, again, unfortunately, I have seen quite a number of times. So I guess the take-home message is, when you are seeing someone for Botox with regard to migraines, just like for migraine or headache surgery or a facelift, it's important to ask what that person's experience with Botox is, how much experience they have with it, and what their results have shown. Okay, and I think those are reasonable questions to ask any clinician if they're going to do something to or for you. I think you should have a very a good answer, and one that you're comfortable with before proceeding. Okay. There's a patient here that asks, again, another very important question: hormones and migraines. What gives? I have worse migraines before my period, during my period, and it has been described in a number of publications everywhere that migraine headaches can sometimes get better during pregnancy, sometimes they get worse during pregnancy. How are the hormones affecting the migraines? And it's a very, very complicated and very, very involved answer. There are any number of theories as to how hormones affect headaches, but the bottom line is that it's not necessarily the fact that the hormones, in this case progesterone and estrogen, which will vary depending upon the place in the cycle that you're in or the phase of pregnancy that you're in. But we know that hormones, for example, affect blood vessels. And so one of the things that happens is that you get a little vasodilatation when you have a certain ratio of progesterone to estrogen. And if you have a large blood vessel that is already encroaching on a nerve, and let's say you are in a certain period in your pregnancy, and the levels of estrogen are higher than they were a month ago, that blood vessel is going to dilate and is going to press on the adjacent nerve even harder. And so in that case, your headaches might get worse. The other thing that happens, particularly toward the tail end of a pregnancy, so late third trimester, as a woman is getting ready to give birth, is that the hormones affect a lot of the joint and ligamentous structures, so the ligaments and tendons. And the main reason for that is actually a functional and physiologic one. In other words, you're going to take a fairly large baby that weighs, let's say, 7.5 pounds, and that baby has to descend into the birth canal and eventually come out the vagina in a vaginal delivery, which is the typical delivery. And in order to do that, the pelvic bones have to become a little bit to allow space to expand so that the baby can pass through the birth canal. In order to do that, the ligaments have to stretch a little bit. Now, in this case, that's a good thing and will allow the birth of a healthy child that doesn't get stuck, so you don't need an emergency C-section to take it out of the abdomen, okay? However, ligamentous laxity in, let's say, the spinal column may be actually a bad thing, because if you have one vertebrae here and another vertebrae here, and they're only supposed to slide on each other this much, that may be good and nice and stable. But let's say you're in your third trimester of pregnancy and now these things really slide past each other. You're going to have a lot of motion in your neck, not only at the bone level, at the spinal column level, but and all of the soft tissue structures that are also within that neck. And so if you have hypermobility and the nerves as well as blood vessels that are passing alongside are now being overly stretched, you can actually get irritation of those nerves and a worsening of your headaches. So those are two prototypical examples as to why certain hormonal changes can impact the degree of neuralgia or the number of headaches that you have. And we've gone over this, I'm sure, because someone asked a question several Facebook Live events ago about weather. How come when I'm the best barometer that there is, I'm able to predict when a storm's coming better than the meteorologist on TV? And the answer is because when a storm comes up, you have a period or a situation where you have low barometric or atmospheric pressure. If you have normal atmospheric pressure, the blood vessels do this. With low atmospheric pressure, there's less pressure on those blood vessels, so they dilate. And again, if there's a nerve next to that blood vessel will impinge upon that nerve, irritate it, and your symptoms get worse, okay? There's somebody asked a really good question. What are the different types of nerve blocks that are used to treat occipital neuralgia? Again, sort of a multi-pronged question, okay? And this person was saying, I've had multiple peripheral nerve blocks and they haven't done a thing, okay? So let's talk about nerve blocks. First of all, you can block a nerve with any type of local anesthetic that you wish, okay? They all function pretty much the same way and temporarily and chemically inactivate a nerve. And if that's a sensory nerve that provides sensation, for example, to the forehead, you will go numb for a certain period of time. The actual type of local anesthetic you use really doesn't matter, but it will affect, depending on the local anesthetic that you use, how long the duration of the numbing will last. So for example, or will be. So for example, if you use lidocaine alone, all right, you may get 30 minutes to an hour of numbness. If you use lidocaine with epinephrine, which will vasoconstrict the blood vessels near the nerve and prevent that local from being taken up and broken down as fast, you may get 2 hours of relief. And if you use bupivacaine, which is also known as Sensorcaine or Marcaine, depending on the brand that you buy, you may get 4 to 8 hours of relief, okay? Now, the results with any nerve block, and this is, again, what I say to my patients when they come to the office, the results with any nerve block are going to depend on a number of factors, 4 of them primarily, as a matter of fact. The first is what you inject, Marcaine, lidocaine, with epinephrine, without epinephrine, number 1. Number 2, how you inject it. That means you got to get the local as close to but not within the nerve as possible, because the more of the local you ladle on the nerve, the more of that nerve will be affected, okay? And that alone, I think, explains a large number of situations in which someone will say, well, I went in for a nerve block 6 months ago and I was so numb and it worked great and I had no pain for X period of time, but he did the same injection this time and it didn't work. Well, maybe the needle was right near the nerve the first time and very far away from the nerve the second time. And so the local just sat over here instead of sitting on the nerve, and therefore you didn't go numb, and the impact or result of that nerve block was not as successful. So number 1, what you inject. Number 2, how you inject. Number 3, where you inject, okay, how you inject it, okay? So in other words, are you injecting them all at once? Are you injecting just one nerve at a time like I do? Because of course, if you take, let's say, a needle and put it in just behind the ear at the scalp and go all the way to the midline and inject 9 milliliters on the way out, you'll have blocked the greater, the lesser, and the third occipital nerve in one shot. And if you get 100% relief, which one of the nerves that you just blocked was responsible for that great result? You have no idea. So along with that, it's not only what you inject and how you inject, but how much of it you inject, okay? So you got to be very careful. You got to inject nerves sequentially. That's my personal belief. The other reason is, and probably the most important reason why there are nerve blocks and then there are nerve blocks, is for what reason you are injecting. Nerve blocks, I would submit to just about anybody I could ever talk to, and I've yet to have anyone convince me otherwise. Nerve blocks are not treatments. They will not fix you. Like any medicine, they will work for a fixed period of time, and when the medicine wears off, the symptoms will recur if this is a mechanical problem. So if you have diabetes, you don't take that one shot of insulin and go, that was great, I'm done, that wasn't so bad. Or hypertension, you don't take the one pill and go, yeah, my blood pressure was fine today, that's it, I don't need to do anything more. No, you got to keep getting those injections of insulin, monitoring your blood sugar, monitoring your blood pressure, and taking those pills once or twice or 3 times a day. Nerve blocks are exactly the same way. However, they are excellent diagnostic tests. And so if you have pain and you block a nerve and you get no result, and the nerve is a sensory nerve and you go numb in that nerve distribution, that means either that this isn't a peripheral nerve problem, or it's not that peripheral nerve problem because you've numbed it. You know that because the patient's reporting numbness in the appropriate place. So you got that nerve, but the pain didn't change. Okay, so maybe it's another nerve that's causing the problem. That's the other conclusion. If you have pain and you numb a nerve and all of the pain goes away, you're pretty much done. That nerve must be causing a significant portion of that pain. And to this person's question, what does it mean when these blocks didn't work? If you block a nerve and you get 30% relief, and then you block another nerve and you have 60% relief, and then you block a third nerve and you have 99% relief, then each of those nerves is likely involved in the overall pain complex, and you have to consider doing something, whether it's doing RFA, surgery on all three of those nerves to give you that same result, hopefully on a permanent basis in the case of surgery, okay? So when someone says my nerve blocks didn't work, what does that mean? Well, if you actually went numb in the distribution of that nerve, it means it's either not that nerve or it's not a peripheral nerve problem. So if you got partial relief, let's say, you know, a lot of people will say, well, the nerve blocks didn't work. And when I say, well, what does that mean? How much, did you get any relief? Thing? Oh yeah, a little bit. It was like 30%, but not much. The presumption could be, or a reasonable conclusion could be, well, maybe they only got one of three nerves that are causing your pain. So if you block that one and one or two others, you might get 90% relief, okay? But of course, this person gets at a right conclusion that is possible also, which is if you block that nerve and you go numb and you, let's say, block all the other nerves and you go numb in those areas as well, and you still have no relief, then the problem may not be a peripheral nerve problem. And in most cases, what that means is it's either musculoskeletal or something that's, let's say, intracranial or central. So maybe it's a blood vessel inside the skull, which of course you can't get to with a needle, or you shouldn't try to get to with a needle. And so in that case, hopefully there's a spine surgeon or either a neurosurgeon or orthopedic spine surgeon that's involved. And most of my patients have imaging of the cervical spine in the case of occipital neuralgia that has basically already evaluated not only the spinal cord, but all the nerve roots coming out of the spinal cord. And in most cases, the abnormalities, if any, that are seen have been ruled out as a potential cause for the chronic headaches that the patients have when they show up to my office. And so that's one way to rule out a more central cause when peripheral nerve blocks may have been unsuccessful. We are close to the end of our time. I really appreciate everybody tuning in. Certainly there are a lot of questions that we can never seem to get to, so please keep them coming in. And if you have any other questions, you can go to our website, which is www.peledmigrainesurgery.com. There's also a phone number, 415-751-0583. You can call and speak to either Christina, who's my front office coordinator, or Carrie Ann Alvord, which many of my patients know. And she is my surgery scheduler and office manager and has been for the last 7 or 8 years. And she's phenomenal. We'd be happy to answer more of your questions in a more personal way, since these can only be sort of general discussions. So if you feel that you have something else that we haven't addressed, either keep the questions coming and we'll try to address them in future sessions, or feel free to reach out and we can try to answer them in another forum. Thank you again for watching, and we hope to see you next time at another Burning Migraine Questions Facebook Live session. Take care. Bye-bye.